Good afternoon, everyone, and welcome to the Science of Childhood Cancer lecture series hosted by the St. Jude Comprehensive Cancer Center. I am Jun Yang from the Department of Pharmacy and Pharmaceutical Sciences, and I'm also a member of the Heme Malignancy Program here at the Cancer Center. So it is my pleasure to introduce our speaker today, Dr. Dave Tichy from Children's Hospital of Philadelphia. Dr. Tichy received his medical degree in Virginia and then moved to Children's National in 1999 for his residency. He joined CHOP in 2002 for his clinical fellowship in pediatric hematology and oncology and rose through the ranks there, and he is currently an associate professor of pediatrics at Penn. He also serves as the director of clinical research at the Center for Childhood Cancer Research at CHOP. Dr. Tichy holds a number of key leadership positions within the Children's Oncology Group, especially on the ALL Disease Committee. As a physician scientist, Dr. Tichy has developed a highly translational research program focusing on TLL. His work in this space has led to the discovery of a number of novel therapeutic agents for this patient population and has translated into exciting COG trials, some of which he's leading. He has received many awards, which I will not have time to list, other than mentioning he is elected member of the American Society of Clinical Investigation and also American Pediatric Society. With that, I'm now going to turn it over to Dave and look forward to our talk.
Thank you very much for the warm introduction. Let me share my screen. Again, thank you for the warm introduction. It's a pleasure to be here today to speak. I'd like to thank the organizers at St. Jude and thank in particular June Yang and Charles Mulligan for the invitation. As far as disclosures, I sit on the scientific advisory board for a number of pharmaceutical companies, and my lab receives some grant funding from 2 pharmaceutical companies. I think one of the great success stories in modern medicine is the improvement in survival for children with acute lymphoblastic leukemia. As people know, acute lymphoblastic leukemia can be divided into 2 types: patients with B-cell acute lymphoblastic leukemia and T-cell acute lymphoblastic leukemia. Historically, children of TALL had inferior outcomes as compared to their B-cell counterparts. But with intensification of therapy, outcomes for children of TALL and BALL are very similar in North America and in Europe, as well as other countries. TALL is quite not there, but it's getting pretty close. In contrast, children of TALL who relapse remain to have a dismal outcome. We have really not moved the bar that much over the past 30 to 40 years, and most children of T-cell acute lymphoblastic leukemia who relapse are not salvageable and do not survive their cancer. T-cell lymphoblastic lymphoma in particular is even worse, where outcomes for that are worse than the 20 to 30% that you see here. So the goal in TLL is really to identify novel therapies and move them to the front line to prevent relapse. So how do we tackle this problem? Historically, to tackle this problem, we would identify patients with lower risk disease and we reduce their therapy, and high risk disease, either based on poor response to therapy or unfavorable biologic features, and intensify their therapy or expose them to novel agents. The intensification of therapy is really, and rearranging the deck chairs isn't going to move the bar any further. As I'll show in a few slides, the morbidity and mortality just from the intensity of our therapy has gotten pretty high in TALL. So the ways we can kind of tackle it moving forward are, one, to improve risk stratification. Unlike BALL, we're actually not very good at identifying patients of TLL that are more likely to relapse, as the main thing that we use to risk stratify patients is response to therapy, and we don't have very good genetic biomarkers. The introduction of targeted therapies is another thing that I'll talk about today, and the incorporation of immunotherapies, which has really lagged behind in TLL compared to BALL. 2 other mechanisms to try to tackle this that I won't talk about today are trying to address clonal evolution and chemoresistance, and then something that's been really pioneered at St. Jude, which is modifying therapy based on host polymorphisms that can affect drug metabolism, tailoring conventional cytotoxics to the patient. First, I'm going to talk about introducing targeted therapies. There are a number of new agents that are potentially interesting in patients of TLL based on disease biology, and I'm going to walk through some of these. Unlike BALL, where you can neatly put patients into boxes, TLL is more genetically heterogeneous and also more complex. that also gives us the ability to exploit it with novel targeted therapies. Most of the agents, though, that we use to treat ALL in 2021 are the same drugs that we've used for the past 30 years, drugs that were approved before 1980. The first novel therapy that really was shown in the more modern era to be effective in TALL was nelarabine. This is actually a drug that was first invented by Gertrude Elion decades ago and kind of sat on a shelf. In the ALL 0434 clinical trial that was run for the Children's Oncology Group that was run by Stuart Winter and Kim Dunsmore, randomized patients to it was a 2x2 factorial randomization to get Capezi methotrexate versus high-dose methotrexate, and patients of intermediate risk and high risk TALL were randomized to receive or not receive nelarabine. Most patients on this trial got cranial radiation. The results of this trial have been published in a number of recent high-impact publications in the Journal of Clinical Oncology. The bottom line of this trial was patients who were randomized to receive Capezi methotrexate had improved survival as compared to those who received high-dose methotrexate, which was different than BLL, with a similar question on the 0232 trial. And patients who were randomized to receive nelarabine also had improved event-free survival. Of note, patients with lymphoblastic lymphoma did not have improved outcomes on this trial. However, it was not powered to answer the question in lymphoblastic lymphoma. Most of the improvement in survival was a reduction of CNS relapses, because nelarabine penetrates very well. Other novel therapies that are being looked at in TLL right now include proteasome inhibitors. So in non-proliferating cells, IKB sequesters NF-kappa B to your cytoplasm. During times of cellular stress, IKB is ubiquinated and degraded by the proteasome. This allows NF-kappa B to dimerize, translocate to the nucleus, and activate transcription of a number of genes and downstream pathways. Tumors that have elevated or activated NF-kappa B are usually susceptible to proteasome inhibitors, not always, such as multiple myeloma. Preclinical models and preclinical studies have shown that NF-kappa B and a lot of its downstream pathways are activated in TALL, raising interest in TALL in particular. Other things that made people interested in TALL is that proteasome inhibitors can synergize with chemotherapy. They can be used to overcome chemotherapy resistance, in particular corticosteroids. Tirza Horton ran a clinical trial through the Children's Oncology Group, ALL07P1, that integrated bortezomib into relapsed and refractory T-cell acute lymphoblastic leukemia and lymphoma that had very impressive outcomes. There are a number of proteasome inhibitors out there. The first generation proteasome inhibitor, bortezomib, that drug is actually being studied right now in Europe in the AOPB BFM 2017 trial in BALL, and is also being studied in St. Jude and Total Therapy 17 in TALL. There's a number of second generation proteasome inhibitors that I won't talk about today, including carfilzomib and azaximib, which are in early phase clinical trials in relapse and refractory disease. A clinical trial that I was the chair on for the Children's Oncology Group was the ALL1231 clinical trial. This trial randomized patients to receive or not receive 4 doses of bortezomib during induction and delayed intensification for a total of 8 total doses. Patients are risk stratified primarily based on MRD response into 3 different risk groups: standard risk, intermediate risk, or very high risk. Standard risk patients got a single intermaintenance phase of Capezi methotrexate. Intermediate risk patients, because we did not know the results of 0434 at the time we developed the study, we hedged on giving 2 intermaintenance phases, one of high-dose methotrexate and one of Capezi methotrexate. In very high-risk patients, defined as having positive MRD at the end of consolidation using a threshold of 0.1%, or being induction failures, received intensification using 3 blocks from the BFM. After those 3 blocks, if you were MRD negative, you continued on chemotherapy. If you were MRD positive at any level, you came off study. One of the main things we also wanted to do in this study was eliminate cranial radiation in the majority of patients. The concept of doing this was really pioneered by Dr. Pui at St. Jude and also some physicians and scientists in Europe in the ERTC group, and had already shown that you could eliminate radiation in a large majority of patients of ALL. We had not done it in the COG yet. On the predecessor study, 0434, greater than 90% of children received cranial radiation. On 1231, less than 10% of children received radiation. The only children who got radiated were patients with very high-risk disease or with CNS3. Patients with T-cell lymphoblastic lymphoma were treated exactly the same way. The only difference is we risk stratified patients by MDD at diagnosis and then day 29 radiographic response. The study ended up closing early after 847 patients enrolled because the predecessor study 0434's results released, which showed an improvement, as I showed earlier, of event-free survival on the nelarabine arm. 1231 did not include nelarabine. It was actually designed a priori to be able to add nelarabine to the backbone if 0434 was to show that that trial was successful. But it was so successful and the baseline EFS was so much higher on 0434, it was felt to be infeasible to add that to the backbone in patients with TALL on 1231. So after closing at the end of 847 patients, if you looked at the 3-year EFS, and this is actually held up at 4-year EFS, there was a trend towards improvement on the bortezomib arm, which was arm B, but there was no difference that was seen that was statistically significant. If you looked at overall survival, we saw a similar trend, this trend towards improvement in overall survival, but it didn't cross statistical significance. However, if you started looking at patients based on their biology, if they were T-cell acute lymphoblastic leukemia or T-cell lymphoblastic lymphoma, we did find something that stood out. Patients of T-cell lymphoblastic lymphoma had an improved 3-year event-free survival and 3-year overall survival that was pretty striking on the bortezomib arm. These are 3-year data, but we've also shown this in 4-year data that it actually holds up. In TALL, in contrast, the survival at both event-free and overall survival was the same on both arms. Kind of laying that out so you can see it side by side, comparing the results that we saw overall children with lymphoblastic lymphoma and children with lymphoblastic leukemia side by side. You can see the difference in outcomes between lymphoblastic lymphoma and leukemia. This actually kind of changed the paradigm because historically we've always thought of TALL and T-cell lymphoblastic leukemia to be a spectrum of the same disease. In the 1231 trial, one of the things that showed is they're not necessarily a spectrum of the same disease and may benefit from differential treatment. One thing we also noted was we increased the intensity on 1231, and when we compare that to 0434, we did find that while event-free survival was similar on 1231 and 0434, we did see a reduction in overall survival on the 1231 study. This is primarily due to toxic deaths. We'll have to see with time if this holds up. Toxic deaths actually impact overall survival before relapses do, which take longer before they're going to impact your overall survival. So we may find out with time the EFS and OS line up, and either 1231 was inferior to 0434, or it was both EFS and OS, or it was similar. One of the other things that we looked at is we compared MRD on 1231 and 0434 because we used a different induction corticosteroid. As part of trying to eliminate radiation, we gave everybody on 1231 a dexamethasone-based backbone, where in 0434 patients got a prednisone-based backbone. We did find there was a reduction in MRD in 1231 as compared to 0434 using a threshold of 0.1% at day 29. And as I showed in the slide before, that this did not impact event-free or overall survival. As I mentioned before, one of the other goals in 1231 was to see if we could eliminate cranial radiation in the majority of patients. Patients on 1231, about 10% of patients received cranial radiation. As I mentioned before, 90% of patients on 0434 received cranial radiation. If you compared similar patients on the 2 trials, so patients on 0434 who did not receive radiation with patients with 1231 who did not receive radiation with patients on 0434 who did receive radiation. So this is a subset analysis, not looking at all the patients. We found that outcomes were equivalent looking at the different arms on 0434 and the different arms on 1231. So we were able to successfully eliminate cranial radiation in the majority of patients. This isn't a perfect comparison because one of the main ways we risk stratified patients on 1231 was in consolidation MRD, and not all patients on 0434 had in consolidation MRD. Another thing that we recently looked at on both 0434 and 1231 was outcomes by CNS status. As many people know, in B-cell acute lymphoblastic leukemia in particular, having CNS3 disease portends worse outcome, but CNS2 disease, where you have detectable blasts in your CSF, but not an elevated white count in your CSF beyond 5 whites per microliter, has been also shown to have inferior survival. Nobody's really looked at this in TALL on a large scale. And when we looked at this on the 0434 data, and these are data presented by Nathan Gasai at ASCO this year, we found that in TALL on the 0434 backbone, outcomes for children of CNS1 and CNS2 disease were comparable and no different. CNS3 did do worse. On 1231, we saw the same phenomenon. So without radiation, we also found that CNS2 was not prognostic in TLL, and outcomes, if anything, were slightly better in CNS2 patients as compared to CNS1 patients. CNS3 patients, despite radiation, did worse than CNS1 or CNS2. So we need new therapies for patients of CNS3 because despite intensive chemo and radiation, at least in the children's oncology group, a high percentage of these patients continue to relapse and not survive. To make sure we didn't confound for other variables that may have impacted our interpretation of CNS1 versus CNS2, when we drilled down just on intermediate risk patients who were treated exactly the same way, we found the same results where the outcomes for CNS1 and CNS2 were the same. One of the other things that we wanted to do was try to find out if there were certain patients who did particularly bad on the 1231 study that could also explain some of the worst outcome potentially compared to 0434. As I mentioned before, we risk stratified patients based on disease response. We expected 10% of patients to be very high risk based on either an induction failure or being MRD positive. However, we found it was much less, it was only 4%, and the outcome in these patients was particularly poor. It was quite dismal. On arm A, the non-bortezomib arm, it was less than 40%, and arm B, almost nobody survived on that arm. Both event-free and overall survival look comparable. Over 95% of patients, though, were standard or intermediate risk, and those patients did well on both arms. So on 1231, by intensifying therapy, we selected for a very highly resistant chemorefractory group. To show that in addition, kind of drilling down on the very high-risk patients based on how they were defined, as I mentioned before, patients who were incondylation MRD positive received 3 intensification blocks. If they were MRD undetectable, they got chemotherapy. If they were MRD positive, they went on a stem cell transplant. While the N is small, only 25 patients were in consolidation MRD positive, and not all of them made it through the intensification blocks. The difference in outcome was striking. So patients who were MRD undetectable, even though there was only 8 of them, and continued to receive chemotherapy, had a 3-year overall survival of 25%. In contrast, after very intensified blocks, patients who remained MRD positive and went to transplant had a 3-year overall survival of 90%. So while the sample size is very small, comparing 10 to 8 patients, the difference in outcome is pretty striking with an overall survival difference of 25 versus 90%, showing patients who remain having MRD positivity at the end of consolidation should go to stem cell transplant in first remission. When we looked at outcomes for induction failure patients on this, there weren't that many, there were only 10. Their overall survival was pretty good, but didn't allow us to do any kind of subset stratification based on MRD. But if we looked at patients who were M2 or M3 or had greater than 5% blasts, higher defined as induction failure in most of Europe and some other cooperative groups, and then broke that down by MRD, if you were an induction failure patient who was induction MRD negative, your overall survival was very good at 87%. If you were MRD positive, your overall survival was worse at around 60%, showing that MRD at the end of consolidation really does trump being an induction failure in patients with TALL. I think one of the reasons that the outcome at 60% here is some of these patients went to transplant and some did not. On 1231, one of the things that we wanted to do was to understand the biology of TALL better. So for this, patients who enrolled on the trial had the option of having samples collected on study, and fresh samples were sent to Terza Horton's lab where they were processed for proteomics. They were then transferred to Michelle Hermes's lab where they had phosphoflow cytometry, and I'll show some of these data. The proteomics was done by a combination of Terza Horton and Steve Kornbau's lab at MD Anderson. Samples were also sent to my lab where they underwent some genomics, and they also were put into PDX models so we could test some targeted therapies. We also did comprehensive immunophenotype looking for targetable antigens so we could develop immunotherapies for these patients. And they went to Brent Wood's lab where they had both flow and next-gen sequencing MRD to see if next-gen sequencing MRD was better at determining outcome than flow MRD and TALL. As I mentioned, Terza Horton's group has been performing proteomics on all these patients on 1231, and I'm not going to steal her thunder by showing a lot of the data now, just to say that there's some exciting data that she'll be presenting at ASH this year, where she found if you did proteomics using a reverse phase protein array, patients could be clustered based on their proteomic signature. This assay allows you to look at over 300 different proteins and their phosphoproteins. And she actually took patients could be clustered based on their proteomic profile. And then looking at outcomes on bortezomib versus the non-bortezomib arm, some of the clusters had worse survival if they received bortezomib versus some patients in the other clusters had better survival if they received bortezomib. And then drilling down to see what proteins differentiated them, she's identified a number of proteins that actually correlated in their expression of those single proteins with response or benefit on the bortezomib arm, which we're now studying the biology. Some of the proteins that she found with this were actually the same ones that were published on using a randomized trial of bortezomib on patients of AML on the AML 1031 study, a study that was by Richard Aplunk, which is interesting that we're seeing some of the same biology that predicted response to proteasome inhibitors. So even though the overall results of 1231 showed proteasome inhibitor bortezomib had benefit in T-cell lymphoblastic lymphoma, these data suggest there may be a subset of patients of TALL who will benefit from proteasome inhibition. Moreover, we can study the biology and see are maybe the proteins that are enriched in the patients of TALL who may have benefited, maybe they're enriched as a whole in patients of T-cell lymphoblastic lymphoma. And we're looking at those questions right now, in addition to studying the microenvironment, to see if that helps tell some of the difference. Another thing that we did is for patients who were enrolled on 1231, they had samples that were sent to the Hermiston lab at CHLA. A very talented, actually MD PhD student in their lab, Lauren Meyer, did some of the work that I'm showing right now that was published in JCI this past year. And this was looking at resistance to corticosteroids using a combination of samples from ALL 1231 and 0434. What they found is ex vivo, 1/3 of the samples were steroid resistant by phosphoflow when cultured with IL-7, and that JAK-STAT inhibition could overcome steroid resistance. Steroid exposure was shown to augment IL-7 receptor expression and downstream JAK-STAT signaling through phospho-STAT5, and this could be overcome with ruxolitinib. Using CRISPR-Cas9, they did some elegant work where they knocked out STAT5A, STAT5B, and STAT5AB in TLL cell lines. They found that knockout of STAT5B and not STAT5A attenuated dexamethasone resistance of IL-7. My lab did some RNA-seq on some of these samples and found that STAT5B mediates upregulation of BCL2, and you could also reverse this by targeting BCL2 with venetoclax. So that the mechanism of steroid resistance in TLL, they also found it primarily occurred in early stages of development and could be abrogated either with ruxolitinib or venetoclax. And this result was kind of in findings for data and studies that had come out of my lab and had also come out of St. Jude years before, showing that early lineage TALL, in particular their early T-cell precursor phenotype, may be particularly sensitive to JAK-STAT inhibition with the drug ruxolitinib. This has led to a number of early phase trials. Currently, Sarah-Tajan COG is actually looking at this in a type of BALL called PH-like ALL. And it's currently at St. Jude for some patients with no ETP, they're getting ruxolitinib to see if that can improve their outcome. Another thing that Michelle's lab wanted to do was to see if she could develop a clinical assay to identify patients who are intrinsically steroid resistant. A major problem in TALL right now in T-cell lymphoblastic lymphoma is intrinsic resistance to steroids, which has been shown in European trials to affect probably 1/3 of patients. So for this, they looked at the target data, and they used RNA-seq data from 146 diagnostic non-ETP TLL samples to identify a gene classifier that could identify patients who are more likely to be steroid resistant. They found if you looked at MRD and the gene classifier that you had and you split it by a high risk score, patients of ETP ALL, whether they're MRD negative or positive, had a high risk score. But patients of near ETP or non-ETP, you could actually distinguish based on this profile that they identified and their risk score between the MRD positive and MRD negative patients. So patients who are more likely to be corticosteroid resistant because they have persistent MRD at the end of induction. And this was using diagnostic specimens. They found that if you looked at their RNA-seq profile, the high risk score signature near ETP and non-ETPs actually had a gene expression profile that mirrored ETP ALL that suggests there's a subset of more mature T lineage blasts that biologically are more similar to early precursor blasts, which also goes with early T-cell precursor ALL being more steroid resistant. We wanted to look to see if this was dependent on the corticosteroid being used. As I mentioned on the 0434 trial, we used prednisone. On 1231, we used dexamethasone. So we took some cells from PDX mice that we had made in my lab. We made over 100 PDXs from patients on 1231 and applied her risk signature to it and found that regardless of the steroid, we saw the same kind of pattern in MRD negative versus MRD positive patients who were near ETP or non-ETP. And then to try to make this more clinically actionable or actually translate it to the clinic, they took the nice step of moving this from RNA-seq to using nanostring as a technology, which is easier to use in the clinic, and the risk score actually correlated very nicely. So they now have a potentially clinically actionable assay which can predict which patients are more likely to be MRD positive at the end of induction. And in theory, you could integrate this into future trials to identify who's less likely to benefit from intensive steroids, at least in induction. As I mentioned, we really increased morbidity and mortality on the 1231 trial by augmenting the steroid. And the Europeans had already showed us there's a subset of patients of TLL who probably don't benefit from dexamethasone. So at minimum, we could use this risk score to allocate patients who probably wouldn't benefit from 6 per meter squared of dexamethasone in the COG. Another potential and very interesting target in TLL is by targeting SRC and LCK using dasatinib. And this is based on some very compelling data that came out of Jean-Paul Quinn's lab and Jun Yang's lab at St. Jude. Jean-Pierre's lab first did drug sensitivity profiling on 68 cases of ALL with 60 drugs. 24 of them were TAL initially, and then they did a validation cohort. 30% of those were sensitive to dasatinib. They found that there was no ABL class fusion in those, and they did not respond to other TKIs that also should be targeting ABL, such as imatinib. They hypothesized it was due to abnormal SRC activation, and they found it was elevated in sensitive samples. They tried a SRC inhibitor ex vivo and in PDX and found it was also effective. Jun's lab took it to the next step and profiled a large panel of TLL, including adults and kids, and similarly found about 40% of kids and 17% of adults were sensitive to dasatinib ex vivo. They did some nice, elegant work using RNA-seq and a technology developed there called NetBid, and they identified that upregulation of the pre-TCR LCK pathway correlated with response to dasatinib. LCK is in the SRC family of kinases. So this is particularly interesting because there's probably a subset of 40% of patients of TLL who may be likely to benefit from a drug that we know how to safely integrate into intensive ALL backbones. If they could develop a clinically actionable test to identify who those 40 to 50% of patients are, we could then integrate that into a frontline trial where we'd randomize patients who have that signature to receive or not receive dasatinib, which we again know is safe and well tolerated in patients with ALL. Another class and pathway that's been looked at and explored in targeting in TLL for a long time is targeting the PI3-AKT-mTOR signaling pathway for a lot of biologic mechanisms I won't go through today based on time. PI3-AKT-mTOR signaling is frequently dysregulated and activated in patients of TLL in particular. It can also be upregulated and dysregulated in patients of B-ALL, but its preclinical data at least suggests it's more promising in T-ALL. There's been some early phase trials that have looked at targeting PI3-AKT-mTOR in patients with B-ALL and T-ALL. Louis Silverman at the Dana-Farber recently ran an early phase trial that actually showed some pretty promising results using a combination of everolimus on a 4-drug backbone. Unfortunately, only a handful of kids too were TLL in that, so it's hard to know how well it worked, even though it worked very well in B-ALL. Another pathway that's of particular interest to target in TLL by some work initially done by Yannis Iafanis in New York is targeting cyclin-dependent kinases. D-type cyclins, including cyclin D1, cyclin D2, and cyclin D3 have been shown to be important in hematopoiesis and leukemogenesis. D-type cyclins bind to and activate cyclin-dependent kinases 4 and 6 and promote cell cycle prospection. Cyclin D3 in particular is overexpressed and important in T-cell biology, and there's been a lot of interest in targeting it. Work in Yannis's lab show that if you treated mice with T-ALL with the cyclin kinase-dependent inhibitor ribociclib or palbociclib, showed efficacy in mouse models that also would be helpful if you combine it with chemotherapy. Some work that we did in my lab with Karen Bride was we actually looked at combinations of CDK4/6 inhibitors with chemotherapy. CDK4/6 inhibitors have been shown to be cytostatic in acute lymphoblastic leukemia. They inhibit the cell cycle. And there's been a lot of concern if you combine them with chemotherapeutic agents and in vitro models, you may get antagonism if you use them at the same time. By using PDX models in vivo, we actually found that was not the case. And regardless of the schedule, if you gave a CDK4/6 inhibitor before a drug like vincristine, which is cell cycle dependent, you still saw a nice synergistic interaction, suggesting that even though there was some theoretical concern or in vitro concern, that did not hold up in vivo. And based on those data for the Children's Oncology Group, Elizabeth Race opened an early phase trial integrating the CDK4/6 inhibitor palbociclib with free induction chemotherapy, where they were actually giving them both at the same time. That trial recently completed. It was a phase 1 trial, and that'll be presented at ASH this year. Based on some preclinical data suggesting that both targeting PI3 AKT, mTOR, and cyclin-dependent kinases look promising. There's a study that's ongoing at the Farber right now that's being run by Andy Place that started off with a first cohort looking at just a CDK4/6 inhibitor, ribociclib, plus corticosteroids. And then after that, it's going to move into a second cohort that's going to combine ribociclib with everolimus plus dexamethasone to see if that's effective in patients with multiply relapsed B and T ALL. Another area of interest in targeting for T-ALL is looking at targeting the apoptotic machinery, BCL2 in particular. There's been some nice work that's been done by a number of groups that have shown that ETP in particular is dependent on BCL2. In contrast, non-ETP ALL is more dependent on BCXL and probably not BCL2 dependent. Where this translates in preclinical models and probably in the clinic as well is ETP ALL is probably likely to benefit from venetoclax. Non-ETP T-ALL probably needs a combination of venetoclax and navitoclax or other drugs that can target the same pathways but not venetoclax monotherapy. There's been a number of trials that have looked at venetoclax, either monotherapy or combinations with chemotherapy in different leukemias. There's been a number of trials that have been run by Jeff Rubnitz at St. Jude and Seth Carroll with some exciting data. This is one trial that was run by Wendy Stock that was recently published in Cancer Discovery, which looked at combining venetoclax and navitoclax in patients with B and T cell ALL and some patients with lymphoblastic lymphoma. On this trial, they used venetoclax for 2 days, followed by Ven-Nav, and then allowed chemo after it. There was only 7 children that were treated on this, but they had an impressive overall response rate of 86%, and the CR/CR rate was 71%. So this is a very promising combination in very small N data, but with nice, compelling biology as well. And there's a number of groups, and again, as I mentioned, St. Jude, that are planning on moving this forward and looking at larger in T-ALL. There's also a trial in development for the COG being run by Mary-Louise Solis that we're looking at combining venetoclax and navitoclax on a comprehensive chemotherapy backbone for relapsed and refractory T-cell ALL. And our European colleagues for the ITC have a HemeSmart trial that's coming out, which is a basket trial, which is allocating patients of B and T-ALL based on biology. And a number of arms in that trial include venetoclax. So I think there's going to be a lot of excitement in the ALL world with venetoclax, similar to what's been seen in the AML world for the past few years as it's becoming standard of care, especially in elderly adults with AML. One last small molecule inhibitor to mention is OB3424. This is a novel prodrug that is activated by aldoketo reductase family member 1, or AKR1C3. And in tumors that have high expression of this, they're more likely to respond to this because they break down the prodrug. Some nice work that looked in cell lines, PDX, and primary patient samples found that expression of AKCR1 or AK1CR3 was very high in TLLs compared to BALL, and in preclinical models and work that's done by Richard Locke and other groups have shown it's a very promising agent in preclinical models, and there's an early phase trial that's currently in development that'll include patients with relapsed and refractory TLL in North America. So that is one way that we're trying to tackle the problem and improve cure rates in patients with T-ALL. It's introducing targeted therapies by understanding TLL biology. Another way we're trying to improve outcomes is by starting to incorporate immunotherapies. And as I mentioned before, in immunotherapies, things have lagged behind in TLL. As everybody knows, in BALL, a number of immunotherapies, including naked monoclonals such as rituximab, conjugated monoclonals like inotuzumab, which target CD22, bispecific T-cell engagers like blinatumomab, in CAR T cells have shown incredible promise in patients with BALL, salvaging patients that were previously incurable. In TLL, things have lagged behind for a number of reasons. One is target. You can wipe out all of your normal B cells and actually be fine with just giving somebody IVIG replacement. If you wipe out all your normal T cells, you give somebody the equivalent of AIDS, and it just has a high risk for toxicity. So it's identifying antigens that may be more present on TLL blasts than normal T cells, or using it as a bridge to transplant. Another theoretical issue, which is seen as some CAR T, but not all, is fratricide, where basically the CAR T cell attacks itself because the antigen that's attacking is also on the CAR T cells. And the third problem, which used to be more theoretical, it's becoming more worrisome lately, that kind of slowed down the field a little bit, is eliminating blasts from the product, because there's now been cases of patients with B-ALL where there were blasts remaining in the product with CAR T cells. They ended up transfecting or transducing the B cell blasts in the product with the CAR and then giving them back to patients. And in T-ALL in particular, that's more worrisome because it's harder to deplete T cell blasts from a product if patients still have active disease at the time that you T cell collect them to make a CAR. One simple question is, what are the best things to target in TLL? The holy grail will be identifying something that's on TLL blasts, but not on normal T cells. And there's a lot of groups that are looking at this in TLL. Some nice work from Terry Fry. My lab's looking at this a little bit right now too. But before going to that step, just what are some of our common antigens that we may be able to develop immunotherapies and try to translate to the clinic quickly? Some work by Carolyn DiOrio in my lab looked at surface expression of a large panel, in collaboration with Brent Wood, of a large panel of cell surface markers, and some nice work that came out of David O'Connor that was recently published in Blood Advances, looked in relapsed TALL at surface expression. And without going through this in a lot of detail, I would say that the three things that probably have the most peak interest right now are CD5, CD7, and CD38, which are highly expressed on the majority of patients of TALL. If you compare CD38 expression, which my lab's been looking at, in TALL as compared to other lymphoid malignancies, including myeloma, where CD38-directed therapies are very effective, the expression in TALL is comparable to that of myeloma and far higher than other normal lymphocyte populations. CD38 is expressed on activated T cells. In collaboration with Brent Wood, we looked at CD38 expression over time in patients with TALL and found that it was stable with time. One of the reasons we did this, if you look at other cell surface antigens such as CD20, and you look at patients over time with B-ALL, you find downregulation. We did find that CD38, if you looked at B-cell patients, actually downregulated just with chemotherapy, which suggests it probably would not be a good antigen to target. We also found it was highly expressed both in diagnostic and relapse pairs. Before moving into the CAR T-cell space, we looked at a naked monoclonal antibody, daratumumab, in preclinical models of TALL. We were quite surprised that in an immune-deficient PDX model, daratumumab, a naked monoclonal antibody, was highly active. This would have been hypothesized not to be highly active because it typically depends on antigen-dependent cell killing for activity, which doesn't exist in a PDX model, so it shows it's a direct cytotoxic effect. Other groups have actually validated and found the same findings, showing daratumumab is very active in preclinical models, either in monotherapy or of chemotherapy. We found it prolonged survival in mice. This led us to open an early phase trial. It initially included a B-cell cohort, not surprisingly, based on some of our preclinical data. It wasn't effective in B-ALL. In a T-cell cohort, there was a safety phase followed by an efficacy phase, where the plan is if it's effective in an early phase trial, we would move it to the front line in a joint trial between the COG and the Altogether group. That trial has almost finished accrual. There's one more patient to accrue, and the results of that trial should be released soon. All I can say is that I can't go through the data. We are still planning on moving forward with our frontline phase 3 trial using daratumumab. And this is a trial that will be run by Eric Schaefer and Keith August in the US with Mary-Lisa Solis, and then Mats Heyman and AJ Vora. Where in this trial, our plan is to randomize patients who are MRD positive with TLL or have persistent disease, a partial response and not in a CR T-cell lymphoblastic lymphoma, to receive or not receive daratumumab, a total of 16 doses over a number of courses. Based on some of the promise that we saw with daratumumab in preclinical models, this made us want to develop a CAR to CD38. And we did this in a kind of multidisciplinary approach, working between CHOP and PIN, where we developed a CD38 CAR with Richard Aplink's lab, Sarah Tazen's lab, the Sargil lab, Carl June, that we're going to test in TALL, also in myeloma, and also in AML, because it's highly expressed in all three diseases. Carolyn DiOrio and Tiffany Vincent in my lab did a lot of the preclinical work. We initially tested a number of different CAR constructs and have a lead construct that we move forward in preclinical testing. This is a mouse PDX model of T-ALL that we randomized to treatment with the CAR T-cell. As you can see in the top at day 0 versus after 4 weeks and 6 weeks with glowing mice. Mice that received an untransduced CAR or untreated continue to get more advanced disease. We found some of the constructs were partially effective, but not very effective. And then our lead construct put a lot of the mice into remission and was very promising in PDX models working, as well as tisagenlecleucel worked in preclinical models of B-ALL. Caroline tested this in a large panel of T-ALL mouse models. This is looking at luminescence on a log scale, finding that the construct was highly effective in a heterogeneous panel of T-ALL and early T-cell precursor ALL. And based on these data, we will be opening a trial this winter that is going to be treating patients with T-ALL and AML and myeloma with CD38 CAR T-cells that is close to opening. It should have opened actually last year. We have an LLS score that's funding this work, but the pandemic slowed things down a little bit. So it should hopefully open later part of this year, but most likely early part of next year. We wanted to really understand the biology of what CD38 does in T-cell blasts because it's really not known. I'm just going to show a little sprinkling of data, but not go into too much based on time. For this, we have T-ALL blasts that we treated with daratumumab. We have T-ALL blasts we treated with CAR T-cells. We have T-ALL blasts we treated both short-term and long-term in mice. Caroline and Tiffany also knocked out CD38 in a number of cell lines. We're working on doing that in primary cells, and we sent this for metabolomic profiling. CD38 in normal hematologic populations is very important in a lot of metabolic pathways, including nucleotide metabolism. Just as a simple proof of principle, we found that CD38 was important in nucleotide metabolism in T-cell blasts. One thing that fell out that we weren't expecting to see was it appears to be very important in polyamine metabolism. This is showing some data looking at untreated versus CAR-treated versus DARA-treated versus knockout, where you can see a similar phenomenon in your downstream metabolites, although it's more apparent in the CD38 knockout than it is compared to drug treatment. And this is a pathway that's actually targetable with DMFO. So there's some studies ongoing right now that are looking combining this with DMFO inhibitors and CAR T cells. Some nice work from a number of labs has also looked at for other antigens that we might want to target in T-ALL. One is CD47, kind of the don't eat me signal of macrophages that has been highly effective as monoclonal antibodies in T-ALL. And some nice data from ASH this year actually combined CD47 inhibitors with CD38 inhibitors, showing some synergy. We're right now looking at combining a CD47 monoclonal antibody with our CD38 CAR in our mice to see if that can actually increase persistence with time. A lot of groups have been looking at CAR T cells and T-ALL. There's been a number of preclinical studies targeting CD2, CD5, CD7, and CD38. And I think one of the things that's really exciting is in the past year, we're now starting to see some clinical data. There were some data at ASCO, some data at EHA, and some data at ASH last year from some early phase trials targeting CD7 with different CARs from China. Caroline, again, in my lab, has been looking at a off-the-shelf anti-CD7 CAR that's highly active in our T-ALL models that we're working at Beam Therapeutics, and hope to happen a trial for this opening next year in adults and kids with relapsed refractory T-ALL. One of the benefits of an off-the-shelf CAR T-cell for T-ALL is you don't have to worry about the issue of separating your blasts from your non-blast population. So the way we're kind of envisioning it is for patients who we can't get into remission and can't get a good T-cell product, we may offer them the off-the-shelf anti-CD7 CAR. And for the patients that we can get a good T-cell product and separate the blast from out the blast, we'll use the CD38 CAR. Some nice data that were just published in JCO this summer from China, actually the first real publication using CAR T cells in patients of T-ALL. For this trial, they used donor-derived T cells from 20 patients. 12 of these patients had a prior stem cell transplant, and surprisingly, 8 of these patients were stem cell transplant naive. So for them, they collected cells both to make the CAR T and for the stem cell boost, and about half of them were haplodonors. They found that 19 of 20 patients responded. The follow-up is short, but these patients went into CR, and most of them went into MRD negative CR. Again, follow-up so far is 6 months, but the CR rate for relapsed and refractory TLL are quite remarkable, and so this is a very promising avenue to explore. They found their CAR T cells were very well tolerated. They did find patients got GVHD. It was typically grade 1 to 2. They used dexamethasone and ruxolitinib to control GVHD. And surprisingly, that actually did not impact the efficacy of the CAR T cells. Some patients did get low-grade neurotoxicity. There was 2 patients, it was both grade 1. I think about half the patients got low-grade CRS. Nobody got severe CRS. The one side effect that was seen was some patients did have severe infections. There was 4 cases of viral reactivation. 1 patient did die of a fungal pneumonia. That was a patient who had a previous fungal infection. And there's been 1 patient who's had a CD7 negative relapse. But again, early data, highly encouraging. A donor-derived CAR T would be harder to pull off in the US based on some of the regulatory issues that it may be in other countries, but it's a novel approach and very exciting. And based on some of the stuff I've said before in different preclinical models and otherwise, there are a large number of T-cell immunotherapy trials underway. And the hope will be in 3 to 4 years when you start talking about TLL, we'll start talking about the same kind of results in TLL that we saw in BLL 10 years ago with blinatumomab and Tisagen, Leclusel, and inotuzumab and other drugs. And I'm going to kind of close by saying the last way that we're trying to tackle this problem is by improved understanding of T-cell biology, and that involves improved risk stratification. Currently, about 10 to 20% of patients of TLL, we know are going to have relapsed refractory disease. And we predict who's going to do poorly of TLL currently based on response only, primarily based on MRD response. And the majority of relapses occur in patients classified as lower or favorable risk. In COG right now, we found that most patients are MRD negative by the end of consolidation. MRD positivity at the end of consolidation is only about 4% of our patients now. So 95% of patients we say have a favorable MRD response. So that's where our relapse is happening. And that's the population we need to figure out who's doing bad and who's going to do worse and who needs novel therapies up front. Because as I mentioned before, we're not as good at salvaging relapse. And unlike BLL, where there's been a lot of groundbreaking work that's shown what genetic alterations are independently prognostic of MRD, none have been identified yet in TLL that have been reproducible across groups. There are some data from Europe suggesting that if you look at it in a more complicated way, where you integrate genomics looking at multiple genetic lesions with MRD and other clinical variables, you may be able to risk stratify patients. That it may just not simply be a single genetic alteration, but a combination of genes that may need to be mutated or not mutated that will help you put you into risk groups. Probably the largest study of the genomics of TLL came from the Target collaboration between Target, the Children's Oncology Group, and St. Jude Children's Research Hospital, work that was done in Charles Mulligan's lab. This data was presented a few years ago, which did whole exome sequencing, RNA sequencing on about 264 patients treated on the 0434 trial. They learned a lot about novel TLL biology, identifying 106 putative driver genes, a lot of which were novel in TLL. This groundbreaking study actually was able to divide patients of TLL into groups based on pathways that were dysregulated, as I kind of showed in one of the first slides, showing it's also very complex in TLL. There's a lot of overlap in what pathways are dysregulated. And it may be that in TLL, to really figure out prognosis, you can't look at it at the gene level, but you may have to look at it at the pathway level and also integrate it with translocations and other genetic markers. The limitations of this study are, one, it was only 264 cases, and it wasn't powered to correlate genetic lesions of outcome. It didn't include whole genome sequencing, and refractory cases were excluded. The reason refractory cases were excluded was for germline DNA, they used the remission sample. So patients had to be in remission both morphologically and by MRD at day 29, which a lot of patients with TLL still have persistent disease at day 29, and those were excluded for studies. So a lot of our high-risk patients were excluded from that first paper. They did find that there was some association with genomic features and outcome, which was encouraging to say that maybe if you took it the next step and had a larger genomic study to be able to identify ones that are prognostic, a number of genes and a number of pathways as well. As I mentioned before, it primarily included whole exome sequencing. And we know in TLL by some compelling work by a number of labs, Mark Mansour, Tom Luck, and others, that in TLL in particular, alterations in non-coding regions of the genome are highly important and biologically relevant. 3 big papers showed that the tau1 proto-oncogene in TLL had major genomic alterations in non-coding regions that were important. These either included mutations in the tau1 structural loop that led to superenhancers, deletions in the CTCF binding domain that altered the structural loop and activated TLL, and then an acquired interchromosomal interaction between cis regulatory elements that also activated TLL. So 3 different papers, 3 different groups showed that you could activate TLL by 3 different mechanisms that were all in the non-coding part of the genome, which really means if you want to understand the genomics of TLL and identify which genes may be important, you can't just do whole exome sequencing. You need to take it to the next step. As I mentioned before, that nice groundbreaking Target paper did not include a lot of the refractory patients. And we know by other work that's come out of St. Jude, which first described the early T-cell precursor phenotype, early stage TLL has different biology than more later stage TLL. So how are we tackling this problem right now? Currently, as I mentioned, the only prognostic marker in TLL is MRD. So a collaboration between my lab, COG, Charles Mulligan's lab, June Yang's group, Stanley Pounds at St. Jude's. We are, and through an EXO-1 grant, a Gabriella Miller grant, and an R03, we are doing whole genome sequencing, RNA sequencing of tumor and whole genome sequencing of germline of 1,400 cases of TLL that were treated on the 0434 clinical trial, which are going to integrate those data with MRD and try to correlate with outcomes. We can use the 1231 trial as a way to validate it and also look in some of the T-cell lymphoblastic lymphoma samples in that trial. This is a very large collaborative effort. There are a number of promising young postdocs, including Petri Polonen at St. Jude, who are helping to work on this project, plus some people in my lab as well. So the sequencing is complete. Wish to have some data to show you today. 2 months from now, we would have some data to show, but coming out very soon. With that, I'd like to close. I'd like to thank first people I've collaborated with in the Children's Oncology Group for years, including Mignon Lowe, Steve Hunger, Elizabeth Rates, Manita Vitas, who's now at St. Jude, and others, the people who've been working on the 1231 biology, Michelle Hermiston, Teresa Horton, Brent Wood, the people I talked about that we're collaborating with to lead the next generation of T-cell trials, and some of my collaborators in the Lymphoblastic Lymphoma Committee, collaborators and colleagues at St. Jude's. It's always a pleasure to work with them. Members of Charles and June's and Stanley's lab, Dr. Pui, one of my idols, people at Shop and Penn, including Steve Grupp, Carl June, and people who worked on a lot of the immunotherapy stuff, Warren Pear on some of the biology stuff, other collaborators both in the US and abroad, and then of course, last but not least, the people in my lab who did a lot of the work that I showed today, Tiffany Vincent, Caroline Dorio, Junior Hall, Terry Ryan, Carrie Bride, Tori Fuller, Abinu Gab, Sue M, Rowan Shame, who's a brilliant bioinformaticist that recently joined the lab, Haley Newman, a new postdoc in the lab, Jess Lee, Thomas Lang, Sydney Diamato, and Viet Tron, and then of course, people who funded this work. Thank you.
Thank you, Dave. That was great. So we have quite a few questions coming in already. As I said, please enter your question in the chat box and make sure to send it to all panelists. So maybe I will start with a question on my own. The CD38 data was very interesting, especially you show when you knock out CD38 and you see an increased level of ATP, ADP. And I wonder if that necessarily means that when you inhibit or suppress CD38 signaling, you have an increased dependency on purine synthesis. And if that's true, does it indicate potential synergy with methotrexate, thiopurine, or even the narrabine in the context of TLL? Would that be something to consider for future trials?
That's an interesting question. I actually hadn't thought about that angle, really. I should have, but potentially, and it'd be an easy enough thing to test. I mean, I wouldn't want to do that in patients necessarily treated with a CAR, but in patients who are getting like daratumumab, to use it, to any data that would suggest it may synergize with certain chemotherapeutic agents would be something that would be compelling to test. The same phenomenon that we're seeing in T cell blasts is actually what we're Sargil's doing some nice work in normal T cells, and a similar phenomenon seen when you knock out CD38 in normal T cells too. So it's actually similar pathways in both that are dysregulated.
So we have a question about your T cell lymphoblastic lymphoma data. Is about whether constitutional mismatch repair deficiency is related in that context is related to prognosis.
It's a good question. Probably, although I haven't seen any large compelling data that it necessarily is. And when you say my lymphoblastic lymphoma data, I guess I would ask the speaker what data they're referring to, because almost all the data I showed was in leukemia. I mean, there's some nice data from Europe. Elizabeth McIntyre's group and Mark Mansour have done a lot more work in the T-cell lymphoblastic lymphoma space than we have. The 1231 trial is making us now really want to look at lymphoblastic lymphoma a lot more closely, because we've kind of assumed whatever we found out biologically in TLL would just apply to T-cell lymphoblastic lymphoma. We'd be able to do the same things. And we were surprised to find the results on 1231 with the differential response to bortezomib, which proves that they're not necessarily the same disease. And as we move into novel therapies, we're going to have to think about potentially at least looking at outcomes differently. They're too rare to completely split off, or we won't be able to ask this study question. Immunotherapies may be the same thing, that lymphomatous disease and leukemic disease respond to immunotherapies differently too. So I know I kind of dodged around the question, but
We also have a question from Dr. Ralling about 0434 versus 1231. So as you are aware of this, the 0434 randomization, especially high-dose methotrexate versus Capizzi, was somewhat biased because of the timing of irradiation. And so the question is, I think a lot of us have this notion that 0434 didn't necessarily show that high-dose methotrexate is inferior to Capizzi, at least in TLL. So if that's true, then is it possible that the 1231 has worse outcomes than 0434 because of the lack of radiation combined with inadequate high-dose methotrexate on 0434, which results in more patients getting suboptimal therapy on 1231?
It's a great question. First, I'll say that when we compared outcomes in patients on 0434 who were radiated with those on 1231 who weren't radiated, their outcomes are superimposable. So we were able to get rid of radiation on 1231 without impacting relapse-free survival at all. There were not more CNS relapses. There wasn't a Doughboy effect. By getting rid of radiation, we didn't see more CNS relapses, and then that was counterbalanced by bone marrow relapses. We actually had comparable numbers of both. The reason that 0434 seems to do worse is by pushing the steroids, we had more toxic deaths. But actually relapses were actually a little bit lower in 1231 than they were in 0434. So I kind of would answer that I think actually we answered that question, that we can safely get rid of radiation. I've heard the argument many times on the timing of radiation on 0434 impacting the high-dose methotrexate for Capizzi methotrexate. I personally am not a believer in that. So we argue that patients with TLL can be cured without radiation. Yet we believe that giving the radiation 3 months earlier is what actually cured more patients. And I can't believe that something that isn't all that effective anyways, and your overall cure rates makes that big of an impact. So you're basically telling me that there was a 15% improvement in survival based on the radiation being given 3 months different in timing. It's just too much of an effect size to imagine that the timing of the radiation made that big of a difference when radiation actually doesn't help. I mean, the MRC, St. Jude, other groups have gotten rid of radiation in TLL and maintained equivalent outcomes. And COG kind of lags behind in the fact that we still use it. So I am a naysayer to the timing of radiation impacting 0434, even though I know there's a lot of people in the community who make that argument all the time.
Well, it sounds like that's a perfect topic for additional discussion. So it's already top of the hour. I would like to close the official event and thank Dr. Tichy for his wonderful presentation, and also invite everybody to stay on for the extended Q&A, which will be moderated by Dr. Charles Mulligan, Deputy Director of the St. Jude Comprehensive Cancer Center. Before I go, a quick note to please join us next week when Dr. Dave Fisher of Harvard Medical School will be speaking on sunlight and skin lessons for melanoma therapeutics from its unique pathogenesis. So I'll now pass it over to Charles.
Okay, thank you very much, June. And I also echo your thanks, Dave. That was a wonderful talk, and it's really great to see how TALL is having its day in the sun now with all these promising new therapies. So some additional questions, and please, everyone, keep them coming. We have time, and please put them in the chat box addressed to all panelists. So, Dave, a question from Dr. Lissart is, David, did you or collaborator perform bortezomib ex vivo drug response profiling and correlate with clinical response and proteomic subgroups?
It's a great question. Yes, that has been done. Actually, Michelle did some ex vivo work looking at bortezomib, and we're correlating that with some of the proteomic signatures, both by the RPPA array that was done by Steve Kornblau and Teresa Hurton, and some of the fossil flow at Michelle's lab. We're still analyzing that data as we speak, so I don't have anything I can talk about right now, but the work is ongoing.
Okay, great. How would you treat TALL today for someone who's not on a clinical trial? Would it be 0434 with nelarabine and capizzi methotrexate and no radiation, or some other approach?
So my personal approach to treating patients is I usually recommend 1231 based 4-drug induction that includes dexamethasone at 6 per meter squared per dose. I don't give the extra dose of asparaginase we gave on that trial, so just the one at day 8. And then after induction, I move into 0434 like therapy with a single IM of capizzi methotrexate and nelarabine for all patients, radiation reserved only for patients who have CNS 3 disease. And even then, if they're less than the age of 5, a conversation with the family. And then for me, I treat them all risk groups the same. It doesn't matter what your day 29 response is. And I now, while I waffled on this a little bit, if you're in consolidation MRD positive, I recommend stem cell transplant in first remission.
Great. Is there a role for MRD assessment at days 15 or 19 in TALL?
So it's a good question. So we really emphasize the importance of later stage MRD and TALL and identifying this very chemorefractory high risk group that needs novel therapies, whether that be transplant or something else for cure. Earlier time point MRD can be helpful in identifying a very favorable risk group that you may want to evaluate that if you're asking a clinical trial with a novel therapy that has less legs. And whether that's day 15 or day 19 or day 29, some earlier time point, if you have one that can identify that favorable group, I might use that to exclude those patients from a novel agent question since we've pushed the toxicity so high, if that makes sense. So I think it does have its utility. But for patients who are not on a study, I actually don't think it has much clinical utility because we're going to treat you the same way no matter what it shows.
Okay. How was CNS radiation controlled for in the comparison of 0434 and 1231 outcomes? So here, the second part to this question, is it possible in the absence of CNS irradiation, you might have seen more CNS relapses in 0434 compared to 1231, which uses DEX?
It's possible. The way we controlled for it as good as we could is we so low risk patients on 0434 didn't get radiation. That was 9% of patients, a very small amount. And then we really wanted to do apples to apples comparison. So patients that we could actually say they got radiation based on risk stratification on the 2 trials, and then compare their outcomes. It's not a perfect comparison, but I think it was good enough. The question is, did nelarabine make enough of an impact that you could actually get away with a prednisone-based backbone with nelarabine and still not need radiation? And I think that's unknown. I think the data I have right now is with the dexamethasone-based induction, we can definitely get away without any radiation. And on the next study, so in the next COG study, one of the things that we're going to do is we're only randomizing our intermediate risk patients, but we're actually going to look for our standard risk patients, which is the biggest part of the pie, and they're going to get nelarabine, they're going to get dex, and they're not going to get radiated. And then we're going to try to do, which you always hate to do, but it's the best we can do, a historical control comparison to actually look. One of the questions is, with that backbone that I just mentioned that we're now using in the COG, what are our outcomes in kind of more of a real world scenario when you do that? I think TLL in particular is also tough too, because a lot of clinical trials exclude some of the sickest TLL patients. They come in with big mediastinal masses and they're ICU critically ill. You can't do a spinal tap on them. So then you don't know what their CNS status is. So a lot of trials exclude them. So I sometimes think that our all of our phase 3 trials in TALL overinflate their outcomes a little bit.
Okay. I'm curious as to why you recommend Nelarabine for all patients, since standard risk patients on 0434 were not eligible for Nelarabine.
It's a great question. Two reasons. One, 0434 didn't treat standard risk patients with Nelarabine because at that time, people were very scared of Nelarabine because in the relapse setting, the rate of grade 5 or serious grade 4 neurotoxicity of Nelarabine was very high. And I think people were very afraid when they moved to the front line that you would neurologically devastate children. What 0434 showed was Nelarabine actually was extremely well tolerated and very safe. So those kids were excluded because they were worried about toxicity, and then the toxicity wasn't there. So it was probably something about relapse TLL, probably prior radiation exposure, or the way that we treat relapse TLL that had an interaction with Nelarabine. We found it was a very active drug. Relapse TLL has a dismal outcome. Even patients in that standard risk group, if they relapse, they have poor outcome. And we don't risk stratify patients the way that we did on 0434. So 0434 risk stratified you by age, white count, day 29 MRD, and CNS status, but we don't think those are prognostic anymore, and they're definitely not prognostic on or their impact on a different backbone. So how do you even pick that standard risk group if you changed your induction moving forward to know who to give Nelarabine or not give Nelarabine? So based on that, we just do a blanket recommendation of Nelarabine for all.
Okay, great. Your frontline treatment recommendations different for TALL and T lymphoblastic lymphoma?
So right now, no. However, as the 1231 data mature, if we really find that overall survival benefit in lymphoblastic lymphoma holds up with bortezomib, it will raise the question of should we be giving bortezomib as standard to all our patients with lymphoblastic lymphoma, as opposed to Nelarabine, which we always say Nelarabine wasn't powered to show a benefit in lymphoblastic lymphomas, but it's an active drug, so all people are using it in lymphoblastic lymphoma. And we may find ourselves in a place where recommending bortezomib for the lymphoma patients and Nelarabine for leukemia patients. One thing to note, though, is if you look at the bortezomib arm in the lymphoblastic lymphomas on 1231 and compare that to 0434, they're very comparable. If you look at the Capizzi arm, the arm that did better. For some reason on 1231, the lymphoblastic lymphomas on the control arm did worse. And it was all relapses. So they had that decreased overall survival was their relapse-free survival was poorer than it was on 0434. So one of the things we're trying to figure out and tease out too is why did the control arm patients with lymphoblastic lymphoma on that study do worse?
Okay, so another question about Nelarabine, another question about lymphoblastic lymphoma. So do you think there's still a role for Nelarabine in T lymphoblastic lymphoma despite the lack of significant effect in 0434, especially given that the study wasn't powered to answer that question? So
at my center, we continue to recommend Nelarabine in both leukemia and lymphoma, with the lymphoma argument being the same one that I made for the standard risk patients. It's a well-tolerated drug. If you relapse with lymphoblastic lymphoma, those patients have a 10% survival. Like, we cannot salvage those patients. So we should be giving the best medicines we have. And the Nelarabine question wasn't powered to be answered on 0434. There were only 58, I think, patients who were randomized to receive Nelarabine. So based on that, I recommend giving it. The other reason is more practical. So once the 0434 results were released at my center, we started treating TLL with Nelarabine and lymphoblastic lymphoma, not Nelarabine. And then the next day we had a patient show up with 15% blasts. And we're like, oh, we call them lymphoblastic lymphoma, but they're really like a leukemia. Maybe we should treat that patient with Nelarabine. And then we said, okay, anyone who has high blast at diagnosis that's lymphoma, we'll treat them like leukemia. And then 2 weeks later, we had some patients came in who had like 5% blasts. And then we kept on moving the bar saying, we're going to treat lymphoblastic lymphoma patients with any leukemic involvement with it. And then it got to the point that we were whittling it down and thinking on a per patient basis. And we basically said, we're just going to treat them all. And it evolved over like 6 months at my center from a nobody with lymphoblastic lymphoma getting it to everybody getting it.
Okay, Dave, I'll ask you a question if I can. I mean, it's interesting from my perspective to see a dichotomy between B and TALL in that there seems to be a progressive push in BALL to incorporate genetic biomarkers into risk stratification algorithms. That really doesn't appear to be the case in TALL. Obviously, there's still a lot of interest in ETP and similar features, but from looking at the literature, there seems to be that some of the proposed prognostic algorithms using RAS, PTEN, etc., have not really gained the same degree of traction. From your perspective, from the COG's perspective, why is that? The data are not compelling enough, or some other reason?
So part of it is we want to see it validated in an independent data set. So if you look at the European data on that, it actually, different cooperative groups in Europe actually found different results. So if we multiple cooperative groups in Europe had all found the same pattern correlated with outcome, we might be more willing to adapt it if we could validate it in the US. So if our XO1 identifies that using those same genes, RAS, PTEN, actually can be prognostic, then I think we would adapt them in the next trial overnight. So I just think we haven't shown it in the U.S. yet on our backbones or our therapy that they're independently prognostic. So we're still skeptical.
What do you think you might do? Would it just be risk stratification, or would you be thinking about MEK inhibition, for example?
I think at first we would just do risk stratification. So if we in 2 months found out that there were genetic biomarkers that could help us allocate risk on our next planned COG trial, we're going to intermediate risk patients currently defined by MRD. We're going to randomize them to receive or not receive DARA. Standard risk patients, we're not going to put them on that randomization. If we find there are genetic biomarkers who can better risk classify patients into an 80%-ish EFS group and a 90+% EFS group, then we'd use those genetics plus those MRD for the allocation on that randomized question. I think at this point, I probably wouldn't alter therapy because there's no good data that MAP kinase inhibition actually improves outcome even in the relapse setting in ALL, either B or T. As you know, a lot of those RAS lesions are subclonal, so it's hard to know if they'll actually improve survival. So I think eventually, if you had a very high-risk group based on genetics, so you've had some group that we find from doing genomic profiling has dismal EFS, and there is a promising drug, then yes, I could see shuttling them off at diagnosis to maybe getting a novel inhibitor. But I think you'd have to find a group that had pretty poor outcomes to give up what we're currently doing. Okay.
Well, that's all the questions we have, Dave. So thank you once again. This has been really an outstanding lecture and a very good discussion. Thanks to all the attendees for joining, and we look forward to seeing you next week.
Thank you very much. Thanks for having me.
Thanks.
Good talk. Thanks.